What's that?
I look good too.
Wait, you gotta lean over. We don't see you. All right. So today is day number. There's a Kua in the back trying to get some camera time, even though she just meddled in our business over here and tried to get some people not to get some pictures. So today is day number 13, lucky number 13 for our online patients. What do you want to say to those people at home who've been in boot camp for 13 days?
Come on back. Come on back. Come on home. We ready. It's awesome. It's beautiful.
Day 13, people. Let's make it happen. Go. Go.
It's awesome.
Go.
Go. Go. Oh, go.
Akua, any last words from the peanut gallery?
That's right.
Now you got us all. Akua. All right. Day 13, people. Let's do it. Alrighty, so it is time for today's question of the day. And the question of the day comes to us from Kathleen. And she says, I would like to know how to coordinate exercise for COPD, lumbar stenosis, and osteopenia. So that's actually a great question. So the question is, what do we do about the person who's got multiple comorbidities? And what that means is basically multiple medical problems that seem to conflict with each other. A lot of times patients are referred to us and we want them to do certain things. We want them to do a bike. We want them to walk on a treadmill. And often they've been told, hey, you know what? You should never walk on a treadmill, or you should never use an incline, or other things that may or may not be true. May or may not be true. So again, part of the idea of individualizing care is not to treat everybody the same. It sounds obvious, right? But you can't give individual care if everybody is treated the same. So for example, not every COPD patient is the same. Not every pulmonary fibrosis patient is the same. Not every pulmonary hypertension patient is the same. And in fact, they're hugely different. Okay, there are probably similarities between them because, as I talk about all the time, there are much more similarities amongst us than there are differences, but each person has to be treated as an individual and their own personal medical issues have to be taken into account. When I see somebody for the first time, I go through an extremely comprehensive evaluation process in which I want to know everything about them. I want to know all the things that could potentially affect, either positively or negatively, my rehabilitation plan for them, my rehabilitation regime, okay? And so in Kathleen's case, the question is specifically about spinal stenosis and osteopenia, but it almost doesn't matter what the issue is, okay? And this is something that I say all the time. It doesn't matter if you have shortness of breath, chest pain, back pain, hip pain, neck pain, knee pain, ankle pain, shoulder pain, etc., etc., etc. When people have any type of discomfort, they will generally attempt to avoid the things that cause them that discomfort. So in the case of shortness of breath, we talk about the fact that most people start to get short of breath at high levels of activity. Things like stair climbing, walking uphill, walking fast. But the thing is that if you have back pain or hip pain or knee pain, well, those are probably the activities that cause that discomfort as well. And so the thing is that sometimes we have these different conditions that kind of snowball things way out of proportion. So it's shortness of breath, and then it's back pain, or hip pain, or knee pain, or something else, right? But when it comes to these different conditions, I will always ask my patient, well, what is it that stops you first? So for example, if you're walking on the street, I know that you have to stop after a half a block, but are you stopping because you're short of breath, or are you stopping because your back hurts? All of these things help to clarify not just the diagnosis, but help to clarify what are the things that are making my patient unhappy and uncomfortable, and what are the things that are preventing my patient from being able to live the life that they want to live. So spinal stenosis is very specific. So it comes with pain, stiffness, can cause muscle weakness. That's the gist of spinal stenosis. Now, osteopenia is different, okay? So osteopenia has to do with thinning of the bone. So how do we build up bone? There's obviously medications for that, but also weight-bearing activities. So some people might say, well, this is a challenge because with spinal stenosis, weight-bearing activities can be a problem, but you need weight-bearing activities to treat the osteopenia or the osteoporosis, right? And then we have the shortness of breath thrown in for good measure. So I always think it's better to kind of address, sort of level 1 problem, level 2 problem, level 3 problem. So again, my question to you would be, when you're walking, do you stop because you're short of breath? Or do you stop because you have back pain? Now, nobody stops because their bones are thin, right? So it's not the osteopenia that's stopping you, but the osteopenia is definitely a concern. So if you stop because of shortness of breath and you can tolerate the back, then we have to work on conditioning you, okay? And we have to work on, improving your cardio fitness. We have to improve your endurance. We have to improve your strength and your aerobic capacity. And we do that with vigorous exercise. But we have to keep in the back of our mind the fact that Kathleen has spinal stenosis. And so we want to make sure that nothing that we're going to do for her shortness of breath is going to make her spinal stenosis worse, right? So when you have an orthopedic problem and a cardiopulmonary problem, again, the question becomes, well, which one stops you? Is it the orthopedic problem or is it the cardiopulmonary problem? Now, here's the thing. If it's the cardiopulmonary problem, then we need to condition you, but we need to make sure that we don't flare the orthopedic problem. Now, if it's the orthopedic problem, now listen to this. This is the crazy part. If it's the orthopedic problem and you have to stop because you have back pain or hip pain or knee pain, then that can actually be contributing to your shortness of breath because you don't get an opportunity to challenge yourself in any type of cardiopulmonary way, because what happens first, you wind up with musculoskeletal pain. And so that's kind of what you do in those situations. And then the osteopenia is something that may or may not affect you functionally on a daily basis, okay? But it's something that we certainly want to address, and something that you want to be addressing with your physician and maybe even a specialist. But that's the idea. When people have multiple medical conditions, the question is, which is the condition that limits you most? And sometimes it's difficult to tell. So for example, when you have coronary disease and you have respiratory disease, right? Because when you have heart disease and lung disease have symptoms that are often extremely similar. So shortness of breath is a non-specific symptom. Chest pain or pressure, it's somewhat specific. It's more specific than shortness of breath, but people with lung disease can have chest pain or pressure. People with heart disease can have chest pain or pressure. People with heart disease can have shortness of breath. And you don't want to bet your chips on it being lung disease without fully assessing the heart. And that's why I always say I look at the things that are the most dangerous first. I look at coronary insufficiency, arrhythmia, heart failure, and when those things are ruled out, then we can start looking at the other things. But I don't want to make an assumption that it's either your COPD or that you're having gas or that it's reflux or that and then be surprised and find out, no, it's really your heart. And another interesting thing is that very often patients with respiratory disease are misdiagnosed or undiagnosed as having heart disease because, again, as I mentioned before, their activity is limited by shortness of breath before we can elicit any cardiovascular or hemodynamic endpoints. So what'll happen a lot of times is someone will start a rehab program and they'll get in shape, and now all of a sudden they can do things that are actually eliciting what are really cardiac symptoms that may have been pushed off or attributed to their COPD for 20 years because they never actually got up to a level of exertion to elicit those symptoms because of shortness of breath. So in other words, you get a stress test, the test stops because A, it's usually too vigorous, B, you're short of breath and your legs hurt, right? And so I get a lot of stress test results that say negative for coronary ischemia, but the patient only did a minute on the test. And so to me, that's not a very valuable test, because if you're stopped by a non-cardiac endpoint, then we can't make a determination, and we can't make any assumptions about do you have heart disease or not. So the idea is keep an open mind, keep the main thing, focus on the big symptoms first, focus on the most prominent symptoms first, and focus on the most dangerous symptoms first, okay? And then once that stuff is ruled out, then we could go to the uncomfortable symptoms, or the symptoms that make us uncomfortable, but that aren't gonna kill you, all right? So wrap up is COPD, spinal stenosis, osteopenia. I would say, what's your number one symptom? Is it shortness of breath or back discomfort? If it's shortness of breath, we condition you without flaring the back. If it's back discomfort, we treat the back simultaneously while we condition you to treat your shortness of breath. And we focus on programs that are also going to help improve or prevent the worsening of osteopenia and osteoporosis. All right? Great question. I love the topic, love talking about people with complex medical conditions or multiple medical conditions, and being able to figure out that puzzle and Rubik's cubing it and twisting it and turning it and prodding it and poking it enough until we come up with something that works, okay? Have a great day, everybody. Day 13.